Okay, so cancer and HIV, more or less an overview. So learning objectives for today's session would be to describe the changing epidemiology of cancer among persons living with HIV, to discuss the mechanisms underlying the increased risk of cancer among persons living with HIV, and as well to discuss methods to reduce that risk of cancer among our patients. So this is more or less a list of the AIDS-defining conditions that we're all very well familiar with. And those diseases circled in red would be the neoplastic conditions that are in fact AIDS-defining, so-called AIDS-defining cancer. So Burkitt's lymphoma, immunoblastic lymphoma, invasive cervical cancer, was added in 1993, Kaposi sarcoma, lymphoma not otherwise specified, and Prevalent lymphoma of the brain. So pretty much they're all non-Hodgkin type lymphomas. And these are just, so the top picture is a picture of someone with Kaposi sarcoma, and the bottom image is someone with primary brain lymphoma. And one thing that we know epidemiologically in the ART field is that antiretroviral therapy has significantly reduced the incidence of AIDS-defining cancers. So over the past 20 years or so, AIDS-defining cancers have decreased by more than threefold. And this is from a 2011 paper. But that quote is not complete, and we're going to get to the second part of that quote in a little bit, but we will go through an explanatory process before we get to that second piece. So there's been what we call a graying of the epidemic. So to the right of this slide is an image from 1987, the very early days after the discovery of HIV as a cause of AIDS, when AIDS was primarily, at least in the US, a disease of young gay men. And fast forward 30 odd years, it's now a disease where the face of HIV is of an older person. So in 2015, over half of those persons infected with HIV in the United States were older than age 50. And that has significance with respect to the disease burden that we see going forward and what the response has to be from a public health standpoint. And AIDS as a diagnosis, meaning CD4 less than 200 or with an indicated disease defining AIDS, is more prevalent among older persons with HIV. So that graph would be a graph of persons who were diagnosed with AIDS, not just HIV, AIDS, in the United States in 2010 by age group. And as you can see, as the age group gets older and older, the proportion of persons with an AIDS-defining illness or AIDS-defining condition is over 2/3 once you hit 50 years and above. And why is that? So there are a couple of different reasons. One, elderly persons are often not perceived as sexual beings by healthcare providers. So they are not given, they're not asked about safe-sex practices, they're not offered condoms, they're not screened for STIs and HIV. Also, elderly persons do not often perceive that they are at risk of HIV. So for example, you would find that a postmenopausal woman might stop using condoms because they do not have to worry about pregnancy and would not necessarily be concerned about the possibility of HIV infection if she's having relationships with men of her own age. She would not perceive them as being risks of HIV. That's a young person's thing, right? And men similarly, right? And HIV/AIDS is not usually entertained as a diagnosis in older persons until all other possibilities have been excluded. So I'm sure the physicians in the room have had that sort of experience where someone comes to us after being sick for 4 or 5 months. They've been losing weight, fevers, they've had some night sweats, they have some rash, and they would have gone through a battery of tests looking for lymphoma, looking for diabetes, looking for all different types of cancer. And it's not until every other diagnosis is exhausted that the clinician thinks, oh, this could be HIV. So that is responsible in part for a lot of the late diagnoses we get among elderly persons. And that again has implications for immunosuppression and the consequences of immunosuppression. Because one of the things the immune system does is cancer surveillance, right? The identification and destruction of cancer cells. And this is another graph showing that the response, the immunologic response to ARV is blunted the older you get. So these are curves which showing the median CD4 response to ART in persons at the start of antiretroviral therapy. The solid lines are the rate of increase in CD4 count over 7 years or so among persons less than 50, and the dotted lines would be the CD4 response antiretroviral therapy in the over 50s. And you can see at about year 5 to year 7, you actually start to see, paradoxically, a decline in CD4 count, even though the persons have been on uninterrupted antiretroviral therapies. These are not defaulters, they're not persons lost to follow-up, these are persons who are taking their medications, and you're seeing, especially in some of the higher CD4 strata, you get a leveling off or decline after 5 to 7 years. And that's as a result of immunosenescence. So the immune system, pretty much after about the age of 20, starts to get gradually weaker. And because you get functional changes, you get fibrosis, you lose some of your thymic function. And so by the time you hit 50, 60, 70, you can't mount a full-blooded response to immune degradation. And one of the things we also know about HIV is a chronic inflammatory disease, separate and apart from it being a viral infection or almost a chronic non-communicable disease once you suppress. It's an inflammatory disease. So the chart on the left shows some inflammatory markers, so high sensitivity C-reactive protein, interleukin-6, D-dimer, cystatin C. And that is the higher those lines go, that is the higher the percentage difference from the general population. So interleukin-6 is somewhere between double and let's say almost 150% higher than HIV uninfected persons. High sensitivity CRP, 150%. So cystatin C also 125%. And they're persistently higher, especially even in persons who are on antiretroviral therapy. So the chart to the left shows what we call T-cell activation. So in the red bars would be T-cell activation, which is a sign of immune activation in persons who live with HIV who are not on treatment. The yellow bar to the right would be T-cell activation in persons who are HIV negative. And the blue bars would be T-cell activation in persons who are on antiretroviral therapy and who are suppressed. But you realize it's not quite back down to normal. Even though they have undetectable viral loads, durable viral suppression, there's still ongoing background chronic inflammation. And why is that important? So I draw your attention to the area outlined in the red square. So a lot of those inflammatory markers that I pointed out just now, interleukin-6, high sensitivity CRP, D-dimer, soluble CD14, which wasn't on the previous chart, and something called lipopolysaccharide. Lipopolysaccharide is the component of bacterial cell walls that is released into the circulation, because one of the things that happens early on in HIV is increased gut permeability. The gut becomes a bit leaky, and bacterial products are able to translocate from within the gut to within the circulation. And those bacterial cell wall products actually set up an inflammatory reaction within the body itself. And lipopolysaccharide levels are associated with non-Hodgkin's lymphoma. Interleukin-6 is associated with all cancers. High sensitivity C-reactive protein, all cancers. And notice that is the case both in persons living with HIV as well as the general population. Generalized inflammation is a cancer-causing event. Right? And when we talk about HIV risk, in addition to all the issues that are specific to HIV, we also have to think about general traditional risk factors, so smoking. So this is a study that was done in 2015 in the US, and what they found was that smoking is more prevalent in persons with HIV, so almost double the rate in that cohort. And in addition, that this chart doesn't quite show, there's also a lower rate of quitting smoking, right? So you have fewer persons who never smoked among persons with HIV, but there's also a trend towards fewer people stopping smoking. And that has obvious implications for cancer causation. And one of the risk factors that is known now to be of the cancer, which is obesity. So particularly now with some of the conversation around newer integrase inhibitors like PLHIV and some of the newer molecules like sinofovir, we are seeing in some of the recent studies significant weight gain in some of the newer agents, and that has both cardiometabolic risk, but it also has cancer risk, right? And some of the older agents, for example, your entenovirs, your statins, your AZTs, and some of the older protease inhibitors as well, predisposed to lack of hypertrophy, so accumulation of visceral fat. And even with some of the newer agents that don't have that same lipogenic, shall we say, profile, in general, we have found that obesity rates around the world are rising. And that is a significant challenge with respect to programming around non-communicable disease management. And as you can see in the chart to the right, in terms of cancers that are associated with obesity, that's almost, that's more than 10 different cancers, from liver to stomach to pancreas to myeloma to meningiomas, all associated with obesity. And viral co-infection with oncogenic potential. So we know that there are certain viruses that carry increased risk for cancer in target organs. So when we talk about human papillomavirus, women living with HIV have a high prevalence of HPV infection with multiple HPV subtypes, as well as high-risk subtypes. And immunosuppression resulting from HIV also increases both the risk of developing squamous epithelial lesions compared to general population, as well as, and it's not stated there, reducing the rates of clearance of HPV. So you get persistent infection with high risk. You have a greater chance of persistent infection with high-risk HPV types. Hepatitis B occurs in 5 to 10% of HIV-infected populations who are exposed to HPV, which is 10 times higher than the rate of that in general population. And as well, you get reduced clearance of hepatitis B. Hepatitis C replication is enhanced in the presence of HIV co-infection, and the rate of progression and fibrosis, which is, again, a step towards hepatocellular carcinoma in HIV, is greater HIV/AIDS hepatitis C co-infection. It's not seen so much in our part of the world because we have lower rates of intravenous drug abuse, but it's still it's significant with respect to chronic liver disease and hepatocellular carcinoma. And it has been found that some proteins that are within HIV itself, so TAT, glycoprotein 120, actually promote tumorigenesis and interact with co-infecting viruses to induce cell formation into neoplastic cells. So what that sort of adds up to is that, so on the left, some of those sociological and host factors, and on the right, some of those viral and co-infecting factors. Both of those things more or less point the person who's living with HIV towards a greater risk of developing cancer. Right? So the second part of the quote that I left out, so over the past 2 decades, the AIDS-defined cancers have increased by more than 3-fold, and the non-AIDS-defined cancers have increased 3-fold. Right? And that's from a study done in 2011. So when we talk about non-AIDS-defining cancers, what do we mean? So we already spoke of what the AIDS-defining cancers are. So Boyce sarcoma, non-Hodgkin's lymphoma, various descriptions, some invasive cervical cancer, and some of the non-AIDS cancers, so anal cancer, right, in men, women, especially in MSM, lung cancer, Hodgkin's lymphoma, and liver cancer. So the rates of those cancers are increasing among persons with mutation. There are non-AIDS-defining cancers where there, however, is not noted to be an increased risk. So breast cancer, colorectal cancer, prostate cancer, and a type of lymphoma called follicular lymphoma. And there are types of cancer that are rare, where there is noted to be an increased risk, but it is not common in clinical practice. So Merkel carcinoma, leiomyosarcoma, and salivary gland tumors. And in terms of the cumulative incidence of HIV by status, we did mention that, yes, the rates of HIV, non-AIDS-defining cancer is rising, but if you look at still the 2 highest cancer types among persons with HIV in the red bars, still non-Hodgkin lymphoma and Boyce sarcoma by a fairly wide margin. Lung cancer coming after that, anal cancer, then liver cancer, and colorectal cancer, and then the other cancers lower down. So one of the issues with the non-AIDS-defining cancers is that they are some of them are associated with worse outcomes. So the top three, Hodgkin's lymphoma, lung cancer, and prostate cancer, actually have an increased risk of mortality in someone living with HIV versus someone who's HIV negative. So in Hodgkin's lymphoma, this is a threefold risk. And with lung cancer, it's about a 1.7 times risk, and with prostate, it's a twice time risk of mortality. But with anal cancer, it's the risk, the overall risk is 1.7, but the confidence interval crosses 1. And with colorectal cancer, again, the average is 1.6, but again, confidence interval is 0.2 to 3.1. Right? And as you see, the curves kind of overlap at one point. And what is thought to be the reason for some of these worse outcomes? So late presentation and advanced stage in diagnosis, some of this might be due to health inequities that persons living with HIV face due to socioeconomic factors, stigma, discrimination. Some of it might as well be due to just lack of screening, right? Among persons with HIV, I sometimes have the issue where a patient presents supported stage in the hospital or some of the other hospitals, equivalents, wherever, and they present with a certain syndrome, and the clinicians fall into that sort of cognitive trap of, oh, what you have must somehow be related to your HIV, not thinking, could this be cancer? Could this be something unrelated to HIV, as opposed to something as like an opportunistic infection? Right? There's also a higher risk of treatment discontinuation and treatment intolerance that has been observed among persons who are undergoing chemoradiotherapy for tumors. There are also multiple drug interactions with some of the chemotherapy agents, whereby with some HIV agents, for example, a lot of the chemotherapy agents are metabolized in the same pathway as some of the non-nucleosides. So you could, for example, get lower lower drug levels of chemotherapy agents because those pathways are reduced. The chemotherapy agents are metabolized more rapidly, and you actually get some therapeutic concentrations of your chemotherapy agents. The reverse is also true, especially with boosted protease inhibitors, where you get inhibition of metabolism of chemotherapy agents, higher levels of chemotherapy agents in the person's circulation, and greater levels of toxicity. And in some of the low and middle income countries, one of the driving factors towards poor outcomes is the relative unavailability to support the person undergoing cytotoxic chemotherapy with hematologic support. If the person needs regular transfusions, regular platelet drop-ups. We all know how difficult it sometimes can be for someone who has a persistent chronic need to get the blood products they need to support them through cytotoxic chemotherapy. So, given these increased risks and these worse outcomes, what can we do to reduce the risk of cancer in our patients with HIV? So, one of the easy, early, low-hanging fruit things is smoking cessation, and this is true for cancer as well as it is for cardiometabolic disease. If you're asked a question, a person with HIV is on epidemic, cholesterol of 236 they're overweight, sedentary, and they smoke a pack of cigarettes a day. What is the most effective mechanism of reducing the cardiometabolic risk? Stop smoking. We can talk about adding statins, we can talk about everything else but stop smoking. Same thing with reducing cancer risk. Yes, everything else is good, but if the person is a smoker, that's a major driver of cancer among persons with HIV. Second, early and universal ART, which thankfully most of the world is doing. The challenge at this stage is access, immunization against HPV and hepatitis and human papillomavirus, pap smears and HPV screening. And I'll just put a little plug for the Women's Health Clinic at the Medical Research Foundation, which is a recent initiative whereby we are performing pap smears on Saturday mornings on women 18 to 45. It's a fantastic thing, spearheaded by Sharon Ladisi and Isha John. Dr. John is doing a fantastic job. Routine anal pap smears. So this is a bit controversial because there is as yet not firm evidence that doing anal pap smears to screen for anal dysplasia actually has an impact on mortality. So there's actually a study ongoing right now whereby they are randomizing patients who are getting anal screening and finding abnormal cells to observation versus intervention, to sort of get the evidence that would drive recommendations with respect to how we go about reducing the risk of anal cancer, which we showed is one of those non-easy-finding cancers that is really affecting, especially our MSM population. Screening for viral hepatitis, especially HPV and hepatitis C. Colorectal cancer screening, so fecal occult blood test. I remember one of my lecturers in medicine speaking about, these stool guaiac tests, or sometimes they actually DNA testing now, should be part of the routine physical examination for everyone. Right? Colonoscopies as well to screen for colorectal cancers. The challenge will be whether or not this is implementable at scale in low and middle income countries, because it's typically done by specialists, many of whom are in private practice. The ones who are attached to public health institutions would not be able to handle the volume of, for example, 50% of, let's say, 6,000 patients in care being referred to them for colorectal screening. Lung cancer screening, again, so some of the guidelines speak to low dose CT of the chest on persons who've had a certain history of smoking, whether it's a 20 or 30 packet history of smoking. The question is that implementable at scale in low and middle income countries as well, right? And this is one of those issues that drive late presentation. If the time someone is diagnosed with lung cancer is the time they weight loss for 6 months and hemolysis, we're missed the boat in terms of early diagnosis when we can get the best outcomes. And finally, screening for substance use disorders, including alcohol abuse, which can drive cancers as well. So thank you very much. This has been essentially a broad overview, so I'll just open the floor to any questions.